we're going to get started, and like last week when we did ACS part 1 for STEMIs, it looks like there are a couple of attendings on. I don't. It's happy I'm happy for attendings to watch, but I'm directing this at the residents on service and the fellows, especially the first year fellows, because I'm going to be talking in broad brushstrokes about a number of different issues. A lot of these issues should have their own discussion and talk, but sort of a beginning of the year, trying to touch base on a number of different issues to at least start thinking about them, and then hopefully learn about them in more detail in the future. So just want to touch base on that. But so let's get started. There's a lot to talk about. Maybe. There we go. So we should start with the case. This is a straightforward one. You're pre-alerted by EMS in the field. They say they're bringing in a 54-year-old gentleman with history of hypertension who comes in with chest pressure and nausea, and they report they believe he has a STEMI on their field EKG, and you're waiting for his arrival in the ER. This is what comes across the scanner before you see him. It doesn't even give you his age or name, so you can't even look anything up. And this is what you see. So again, I just touched on this. We're going to be talking in broad brushstrokes about a number of different issues that will come up, but need probably further clarification with further talks throughout your fellowship. So starting again with a discussion of acute coronary syndromes in general, where what we're talking about, as you guys know, there's a spectrum of disease, all precipitated by the plaques that we all have in our coronary arteries. And when you have a plaque rupture or plaque erosion, there's an acute thrombotic event that, if it is non-occlusive, leads to either a non-STEMI or unstable angina. If there's not much thrombus and not much limitation of flow or timing of flow. If that same plaque rupture or erosion leads to an occlusive thrombotic event, that's when you get an injury current showing ST elevation. That's really the difference. Not much of a difference. So just talking about the epidemiology now at this point of STEMIs, I think these couple of slides are pretty interesting. Starting back when I was a second-year resident, this is how many STEMIs we had. The incident rate per 100,000 person years this is in the U.S. That is, the number of STEMIs have really pretty dramatically decreased, while the number of non-STEMIs have increased. I can tell you that troponin I assay came out about this time. And so some of this is really detecting, calling what we used to call unstable angina, now non-STEMIs. The number of MIs in general have dropped over that period of time, 20 years. So briefly, broad brushstrokes, we're going to talk about reperfusion therapy for patients with STEMI. Again, we're not just talking about this institution, but throughout the U.S. and the world, what is available. So in general, you guys know that the STEMI patient who is a candidate for reperfusion comes in. If they're initially seen at a PCI-capable hospital, nowadays we proceed for primary PCI unless there's some reason not to. If they're initially seen at a non-PCI-capable hospital, it's really dependent upon their transfer times, and you should have a system in place for how to handle these patients based on what their door in to door out time is and what their transfer time is. And we'll talk about this because this is going to be on your boards. But in general, you transfer that patient from that outside hospital if your first medical contact to device time is less than 120 minutes. If it's not, because you're in too rural of an area or your system is not set up to handle these patients, then they're going to get lytics, and then you transfer them out. So I know we don't see that here, but lots of places throughout the country do this because it's a pretty big country. And so it's good. You have to know this for the boards, as well as maybe for your future career. As we all know, primary PCI is the preferred reperfusion strategy, dependent upon their time of symptoms. So it's class 1A if their ischemic symptoms are less than 12 hours. If their ischemic symptoms are less than 12 hours and they're indications of lytic therapy, irrespective of that time that I just talked about, that transfer time. If for some reason, we don't have to go over the contraindications now, but if there are, then you shouldn't give them lytics. You need to ship them regardless of that transfer time. Same thing as if they're in cardiogenic shock or acute severe heart failure. Irrespective of the time delay from the MI onset, you should transfer them for primary PCI. And this may not be necessarily to get the artery open at this point, but to deal with the hemodynamic effects of what's going on and to diagnose them. Now, if there's evidence of ongoing ischemia, 12 to 24 hours after their symptom onset, still should be pursued with referring to primary PCI. Not as strong data, not as strong a recommendation. You basically have to reason not to do this. But this time is important. We're going to focus a little bit on this timing and why it's important. Hey, and here's this slide. If you remember nothing from this talk, I want you to remember this slide, okay? Because this affects your approach. It affects how you should think about these folks afterwards. But this is something that should be burned into your brain. It was burned into my brain when I was a resident and a fellow. So we talk about the golden hour. The golden hour, this is time on the bottom, and this is your mortality reduction from reperfusion therapy. And you can see how within the first few hours, there's a marked reduction in mortality from reperfusion therapy. In fact, in the first hour, there's really almost no increase in mortality that can be seen if you can get that artery open as soon as possible. And this is why time is so important. Just a 45 minutes to an hour really affects, it takes your curve from here up to here as far as your mortality reduction. Once you start getting past even 4 hours, this curve starts leveling out. And especially after 8 hours, there's really not much improvement in their overall mortality. And then after 12 hours, it's pretty much a flat line. And so, you know, this comes up a lot. Somebody comes in with 24 hours of ongoing, that's important, not just stuttering, intermittent symptoms, ongoing symptoms, and they have ST elevation. You're operating on this curve, guys. You're not changing their mortality at all by reperfusing them. Let me say that again. You're not reducing their mortality at all by reperfusing them. That doesn't mean you shouldn't take them urgently, but you need to start stopping and thinking about what else is going on and how best to help this person, okay? So just, this is why time is important. And I know sometimes folks get frustrated when we're operating on this curve down here and I'm taking more time than usual to try and figure out what's going on and figure out the timing of things, but there's a reason for it. So what do you want to know or do in the ED? Quick sense of timing of symptoms, as again, we just talked about, this will guide everything. And there's a difference between hearing a story of, oh, he's been having chest pain for 2 days, and getting a story that, well, yeah, it's been coming and going for 2 days. Whereas, no, Monday night, I had this horrible chest discomfort. It hasn't stopped since. And now we're talking about Wednesday morning. That's a much different story, right? The history is everything. So we're going to do a fairly quick exam, focusing on the vitals and any evidence of heart failure or shock. We're going to talk at the end by shock. Again, if it's a late presentation, this exam slows down. We want to do a quick med assessment, history of any prior procedures, mainly what anticoagulants they're on, any recent PCIs, where it was done, and obviously if they had bypass surgery, we really want to try to know what their anatomy was, if at all possible. Again, this slows down if you're a late or later presentation. They're going to get 2 IVs, get IV flows running if they're not in heart failure, okay? For you guys, again, logistically, you want to focus on getting a STEMI consent signed, obviously, if they're able to do so, and we can talk if it's an obvious one. And at some point, we should talk about what that really entails. It's not a prolonged consent process. So what is our medication protocol in the ED? Make sure they've gotten 4 baby aspirins, either en route or in the ER. We use ticagrelor, 180 milligram oral load, and there's reasons for that. We use weight-based IV heparin, but no more than 5,000 units as they're going up to the cath lab. And again, there's reasons for this. So rushing, let's talk about rushing. So this is another slide that I want you to burn into your brains. And that is how we have done a great job in the US with from just 2005 to 2009 with dropping our median door to balloon time from 88 minutes to 68 minutes. It's fantastic. It's really fantastic. There's a big national pool for that. Get with the guidelines, door to balloon, blah, blah, blah. Look at our 30-day mortality from STEMI patients. It hasn't budged. Now, there are people who say, well, it's just because we're taking sicker patients. And that may be part of it. In fact, I think it's a big deal of it. It may be that we've reached sort of a time period where you're not actually affecting the mortality too much and we're taking sicker patients. So you need to make note of this. And I'm still waiting for it, but there's been talk that we're actually removing the door to balloon time even from a quality metric anymore, because you could argue there's been too much of a focus on that once you get out of this higher range. Once you've got a system in place that actually takes care. It's now more important to actually focus on those other things that we've been talking about. Now, this all stemmed from NCDR, this registry data showing that, in fact, there's thought that there's no minimal time that you can reach. There's no J-shaped curve. So just drive it down, drive it down, drive it down. This is not prospective data. This is just looking back and saying people that get in quicker usually do better. But that's not the same as saying that somebody who comes in with prolonged symptoms, that reducing their door to balloon time from 60 minutes to 55 minutes is going to do anything for that person. So that 5 minutes can be very critical to figuring other things out and not missing things like a ruptured pap muscle. Again, this is based on this. My comments are based on this. So what is the downside? Well, just briefly, interestingly, taking sicker and sicker patients, older and older patients, has some downsides. I think we don't always acknowledge, and the reason I'm just putting this up there is that we don't always acknowledge that even in PCI, our stroke risk is not 1 in 1,000. I hear some people talk about that. It's not. Here's STEMI, non-STEMI, and stable ischemic heart disease. I think this trend, and then you try to adjust it, this trend is indicative of the sicker patient population that we're taking. And you can tell that even in 2016, our stroke rate for STEMI patients is clearly over 1%, which is actually higher than you get with lytics. Arguably, you get hemorrhagic strokes. It's usually more concerning. But this is not a benign thing that we're doing. That's the only reason I'm throwing that up there. So rushing them in there when you really don't have any benefit, when there's clearly some risk, you just need to stop and think. That's all the only reason I'm putting this up there. How can you tell the time? Well, sometimes it's only in retrospect that you get this information, but sometimes it's important to know these curves. This is a troponin without reperfusion, a troponin when you have reperfusion, and CKMB with and without reperfusion. Okay, so again, if you're not quite sure and you only have a single troponin, it can be very helpful to know what's going on. But I'm bringing this up for two different reasons. Number one, you have to know these curves. You have to know, one, that even that without reperfusion, the troponin peak from an index event doesn't occur for 36 to 48 hours after the event. Okay, so if you've got a troponin that's markedly high, you guys know that's at least 6 hours, but trying to time things can be helpful. And unfortunately, if you're already on the downslope, so if you're not quite sure they're symptom-free, you get a troponin now and a troponin 2 hours later, and it's already coming down, you've missed the event by over 2 days. And I think just that is important. Now, that can't help you know what to do immediately in the ER if somebody has ongoing symptoms, but if they don't have symptoms anymore, or they have symptoms of a mechanical complication, this can help you time the event, which can be very helpful. There's a loud noise. I don't know if you guys can hear that. So we're going to talk about some individual issues related to treatment and care in the STEMI patient. I'm going to go through a lot of different issues in broad brushstrokes, mainly for the early fellows to know about what are these issues to think about further in more detail. One of this is this concept of multivessel PCI. We could have a whole talk just about this. Different possibilities are at the time of the primary PCI in a planned to staged fashion, and only if there's ischemia or stress. There's been some data on this. Briefly, I'll sort of talk about these, and these are often reported as positive trials, so revascularize everything. But I think as we've talked about in Journal Club before, I'll say, what's my next slide, that really the only thing you're reducing in every single trial is ischemia-driven revascularization. That's what drives every single one of these trials. So essentially, if you take a conservative approach, you can still document who has significant ischemia. You can still revascularize them, but you get knocked for doing that in these trials, and that drives their primary endpoint. So a lot of us don't feel that this is a good reason to do something in somebody who has no prior symptoms of this. And that's why, still currently, this could change, and we're going to talk about the trial that may or may not change this, is that it's a 2B recommendation to do PCI, the non-infarct related artery. It can be done in selected patients with STEMI and multivessel disease who are hemodynamically stable, either the primary PCI or as a planned stage procedure. Now, why I bring this up is because every institution has a culture, and I think a culture here is that if anything is left behind, we have to do something about that. Why are you not stenting that OM that had a 75% lesion when you open up the LAD? And I think you need to put more thought into it. Again, you've heard me say this before, but what 2B means is you can do it, but you kind of have to explain why you're doing it. And I think that's not really the way it's always thought of here, but it should be. Now, having said all that, I think we talked about this in Journal Club. The complete trial came out. This is, I would consider it to be an outlier, but it's an outlier that needs to be discussed and does lend more credence to doing more complete revascularization. Hence the name of the trial. You can tell they're biased just by the name of the trial. 4,000 patients randomized to culprit only, and I put an exclamation point because really it was fixed. You were almost basically not allowed to revascularize them, even if they had symptoms or a large area of ischemia, versus doing everything, revascularizing everywhere, either in-house or up to 45 days afterwards. So in my opinion, it's biased from the outcome towards complete revascularization. There was in the primary endpoint, which is cardiovascular death or MI at 3 years, culprit only. These are reversed. Yep, sorry, I threw this in yesterday. Culprit only had a higher incidence of the primary endpoint versus complete. I think that shows my bias here by me flipping those. So I flip-flopped these numbers, I apologize. The primary endpoint was more beneficial in the complete revascularization. I want to be clear about that, I apologize. There was a trend toward increased bleeding and contrast-induced nephropathy in the complete group. So what does this mean in general? How do you reconcile this with every other piece of data, either during STEMI or for non-STEMIs or stable angina, which has never ever been shown to reduce MIs or reduce mortality? It's possible, you could argue, that there was an OCT sub-study that looked at evidence of vulnerable plaque in the non-culprit vessel, and there was evidence by OCT that, and we know this from prior IVUS data, that there's more than one culprit plaque erosion, and the STEMI inflammatory state may actually lead to some of those previously stable lesions of being unstable, and treating them may have some effect in this setting as opposed to the stable outpatient setting. I actually think that it also is possible that you're removing your ability to use clinical judgment, which is usually what drives folks. So again, if you open up their RCA, they're left with a 90% prox LAD, even with anginal symptoms, unless it were refractory stage 4 anginal symptoms. Even if large area of ischemia, you are not allowed to revascularize them. So this is really, I would argue, not the way practice is usually performed. Having said that, if you hold our hands tight and you can't do anything, no matter what their symptoms are or their stress test afterwards, you can't do revascularization, then yes, there is probably a benefit of doing everybody. I'll just say patients who are randomly assigned to the culprit lesion only PCI strategy receive guideline-based medical therapy with no further revascularization, regardless of whether there is evidence of ischemia and non-invasive testing. That's a direct quote from the trial. Just want to throw that. So briefly, from back to me, Fadi and I were talking about this recently for STEMI, okay? And we know now that for there's a TAPIS trial we won't get into, where there was a trend for a while to doing a routine thrombectomy in everybody. We've now shown that there's really no benefit, that routine aspiration thrombectomy before primary PCI is not useful. However, that doesn't mean that you can't use it in selected patients. If there's maybe a large thrombus burden, a reason to do so, knowing that there are limitations. It is a class 2B recommendation to use it in selected patients, which means you shouldn't do it routinely. And if you're doing it, you should explain why you're doing it. You should have good reason for why you're doing it. Radial versus femoral STEMI. Somebody said this to me recently about mortality benefit. So this comes from, initially there's the rifle trial showing that in the femoral arm that there's an improved mortality, improved survival in the radial versus femoral approach. So yeah, when you dive into the details, they did say they had adequate expertise in both approaches, but most of the folks were doing radials in this trial. It's a different era. 2/3 of them were using 2B3A inhibitors, and only 8% bivalrudin. So there were a lot of bleeding episodes, and even significant bleeding episodes. This is not how we treat patients in 2020, or really even in 2015. There's the major bleeding. Pretty high actually in radial. So another look at the STEMI radial trial, showing that actually, yes, radial approach reduces bleeding. There is no difference in MACE. These folks were initially trained in femoral. They were doing more than 80% of the radials. This was still 45% use of 2B3A inhibitors. They didn't use a lot of closure devices, and when they did, it was angioseal. So they still had a fairly large number of bleeding episodes. A 7% significant bleeding rate is incredibly high, and clearly drove their events. So I just love throwing this out there. This is a year or two ago. I mean, they overhyped. I don't think it's overhyped using a radial approach, but I think this concept that you're reducing mortality is amazing to me, that we still tout this. So this doesn't get a lot of press. Most recently, the Savari STEMI trial. I think this is the best done trial if you're going to sort of look at folks. These are 5 high-volume Canadian PCI centers. Fadi, that's for you. You needed to be proficient in both techniques. These operators were averaging more than 250 PCIs a year. It was stopped early after 2,300 patients due to futility. So when you have good operators doing a fair number of cases, both when they have to use a fair number of both femoral and radial approaches, so you know how to do both. Your 30-day mortality is what you would expect. There's no difference actually in TIMI major minor bleeding. They're not using a large number of 2B3A inhibitors. Okay. Door to balloon time, slightly higher in radial. We probably don't care too much about this 3 minutes, but it was statistically significant, and the stroke rate was higher. So, food for thought. Not to say you should go to femoral, but to think that you're saving lives or reducing mortality by doing a radial versus femoral approach is suspect. How about anticoagulant versus antiplatelet therapy? So there was this historically, after these trials, Acute in 2006 and Horizons AMI in 2008, there was what I refer to as the move to the bival era. We did it up at Bay State as well. We changed our STEMI protocol from heparin and 2B3A inhibitors to bivalrudin, but critically appraising the Horizon AMI trial, we realized the majority of these patients received 600 of clopidogrel or the newer antiplatelet agents, more powerful, and a majority of them, about half of them, received heparin in addition to bival in the cath lab, which seemed to reduce their acute thrombotic events. So we changed our protocol, and this was a move away from 2B3A inhibitors. So we started moving away, which I think is a good thing, from 2B3A inhibitors from a bleeding standpoint for sure. Then the HEAT PCI trial came out in 2014. I was at this presentation at ACC where Greg Stone attacked the poor presenter who presented this, and it started questioning whether or not we should be using bival in these patients versus heparin. The attack was centered around the how they randomized or how they consented these patients, which was in a retrospective manner. We can talk about that later in detail. But this raised the question of maybe we can just use heparin, especially when we're using a radial approach. And so a lot of centers have moved towards that. So what are the guidelines? Again, you can't interpret guidelines unless you know the data, or you can't modify them. We're using aspirin. You have to load them, either 162 or 325. Clopidogrel 600, prasugrel 60, ticagrelor 180. These are STEMI trials, all 1B recommendations. You still give a class 2A recommendation favoring use of ticagrelor over clopidogrel. I touched base on this last week. I won't go to it any further. We'll stop there. So again, what is our medication protocol in the ER? Baby aspirin, we're using ticagrelor most of the time. I think we could raise the question of whether we should or not with versus prasugrel, but we don't need to do that here. And then weight-based IV heparin, more than 5,000 units. How about lytics? We don't use lytics here for the most part. We used it once, I think, with the COVID time period. Whether or not there's a resurge in the wintertime, I think it's good to know about lytics, especially if you go someplace else where you may actually be using lytics. Here's a question. How about I ask Mansoor? So for this, full dose lytic therapy should be given if the PCI treatment delay exceeds which of the following time thresholds? Mansoor, are you still with us?
Yes, I think it's 2 hours.
Okay. So they have a couple different, they have door to PCI, and then the others are first medical contact to PCI. You're right. If it's more than 120 minutes from the first medical contact to PCI is more than 120 minutes, you should be using lytic therapy if there are no contraindications to do so. Okay. Briefly, adjunctive antithrombotic therapy, aspirin is a loading dose, and then maintenance dose afterwards. The best data is for clopidogrel. If you're less, this is important, if you're less than age 75, it's the 300 milligram loading dose. If you're over 75, the guideline recommendations, because it hasn't been tested using 300 milligrams, you're only giving them 75 milligrams. And this is probably related to the increased concern for intracranial bleeding. But if you happen to get lytics over age 75, you're not getting the 300 milligram loading dose. This could be a board question. That's why I'm bringing. How about anticoagulant therapy? The best data for lytics, aspirin and clopidogrel, is with enoxaparin. That's why it's a 1A. Having said that, most of these patients should be or are being transferred still, not waiting to see if they get reperfused, but transferring them to a center which can perform primary PCI if they fail lytics. For that reason, most referral centers are still putting them on IV heparin for the possibility that we need to take them to the cath lab if they have failed lytics. And that's just a logistical issue. The data is better for enoxaparin versus an fractionated heparin. What are our risk factors for intracranial hemorrhage with lytic therapy? They're what you would expect. Older, female, low body weight, history of hypertension, and if you give excessive heparin dosing. Okay. Again, for the boards, you need to know this. You're not giving lytics a lot around here, but it's important to know. How about adjunctive medical therapy for STEMI? Let's do a quick guideline discussion. Again, we're talking broad brushstrokes here. How much time do we have? Oh, we're doing okay. I'll slow down a little bit. So oral beta blockers should be initiated in the first 24 hours unless there's evidence of shock or heart block. That's a 1B recommendation, and should be continued afterwards for all patients with a STEMI. If you had a heart attack, you should be on a beta blocker. You could argue that if they have a relatively limited infarct and they have normal EF afterwards, they have no angina, do they need to stay up for the rest of their life? I think that's a debatable question, but in general, they probably should be. How about ACE inhibitors, class 1A? The guidelines actually say should be administered within 24 hours to all patients with a STEMI of an anterior location, heart failure, EF less than 40% and less contraindicated. I take issue with this. I think there's good data that we can hurt these people if they're initiated in the first 24 hours. There's no benefit to doing it with those 24 hours, but there is some harm if you drop these folks' pressure. There's good data for that. So I don't know how they gave this I think because the one trial looking at it said you can use them within the first 24 hours. So I would just be cautious in the absence of hypertension of trying to push ACE inhibitor therapy within the first 24 hours. That should be started soon thereafter, or clearly if they're hypertensive, but don't drop somebody's blood pressure right after they come in with a STEMI. And then if you can't use an ACE inhibitor, use an ARB. Aldosterone antagonist, it's a 1B recommendation. If they come in with a STEMI, they're already on an ACE inhibitor and beta blocker. Arguably, you probably should max those out, see what the potassium is. But if their EF is less than 40 and either have symptomatic heart failure or they have diabetes, that's based on the trial we'll talk about. It's a class 2A recommendation that ACE inhibitors are reasonable for all patients who had a STEMI, and there's no contraindications. Again, sometimes I'll hear people say, "Oh, we don't have to use an ACE inhibitor. Their EF is 45%." It's true you don't necessarily have to, but I think there's pretty good data from not necessarily clearly from STEMI patients that an ACE inhibitor might be reasonable for the rest of their life. Obviously, if they're hypertensive, that makes it easy. So we talk about eplerenone. The Ephesus trial show the cumulative incidence of the endpoint being reduced with eplerenone, and so it's something to think about whether or not you add this on prior to maximizing your ACE inhibitor A or B is debatable, but it's something to think about to add on. And I'll leave it at that. Again, all of these issues could be really, we could dive into more detail if we have more time. I'm trying to paint broad brushstrokes and raise issues that you can think about and look into more. I really want you to, first year fellows, talk about mechanical complications in STEMI, because it's not as if we don't have them. There's some sort of sometimes a feeling that, oh, we don't see this anymore in the primary PCI era. That is absolutely not true. I think it is true that it's rare to see them when somebody comes in within 6 to 12 hours of their event and they present and they go for primary PCI. But we see a lot of patients who don't come to us until after the event has been completed. Anything more, as we talked about, that 8 to 12 hours, whether or not we open up their vessel, they're still going to be at risk for these mechanical complications. So briefly, cardiogenic shock they're throwing in as quote-unquote a mechanical complication. You can say it's a pump malfunction. So 1B recommendation to present for revascularization, at least for patients in cardiogenic shock, irrespective of the time delay from MI. I think that's actually not based on the randomized controlled trial, but sometimes what they need more than anything is hemodynamic monitoring and hemodynamic support, which is why going to the cath lab is so important. In the absence of contraindications, lytic therapy should be administered to patients stemming cardiogenic shock who are unsuitable candidates. So if you had to, but that would be a very rare bird indeed. 2A-B for use of balloon pump for cardiogenic shock and STEMI who do not quickly stabilize with pharmacological therapy. We'll talk about shock here in a little bit, but there is great data that you're helping. We still use it. Some of us believe it's still very helpful. And then if you're going to use an Impella, just, no one's using tandem heart around here. 2BC currently, and I don't think that's changed. And I don't see it changing anytime soon for these folks. These are, this is the IABP Shock 2 trial, primary endpoint. It's hard to show much of a mortality reduction in balloon pumps, which is why we were so hopeful that Impella, especially larger Impellas, CP, would improve this. We have yet to show that that's the case, and there's a big question why. But it's frustrating that we don't have a lot of tools that are really affecting mortality in the really sick patients. And that's probably because it's not just one or two issues, it's lots of issues. And once you get into this spiral, this is just representing this death spiral that we know about basically, it's hard to pull them out, especially when you're into the pro-inflammatory state. Why some people get into this earlier than others, why they get into it at all, I think is a matter of issue, but this is hard to fix with just mechanical circulatory support. We're not going to dwell too much on this, but once you fall down this hypotension, decreased perfusion pressure, and get end organ dysfunction, especially when we start down this inflammatory, pro-inflammatory state, this is a tough one to break out of. Briefly, recently, you guys need to know that their SCI has presented that we should start thinking about shock in a different way, and they've sort of proposed stages of cardiogenic shock, much like sort of chronic heart failure folks to some degree, and those go from least risk to high risk. So those are folks who are at risk for going into shock. Those are beginning to go into shock. This is what they would say was the classic shock picture that we're most used to. And then when they're deteriorating, and then they're in extremis. So this briefly would sort of go through this A, B, C, D, E, basically. These are folks who look pretty good, but they just maybe had an MI, basically. They're at risk. Folks that are beginning to go into it, they just had an MI, but they're hypotensive, but their hemodynamics are still not that bad. Maybe they had a pretty extensive anterior infarct, and maybe they're not in shock now, but 6 hours later they could be. So you need to be worried about these folks. These are the classic shock sort of situation. They're ashen, mottled, dusky. They're volume overloaded, they arouse, and they're class 3 or 4 heart failure. What they're trying to point out is if we wait till everybody gets to class C or D before we do something more aggressive, maybe we've waited too long and we should start doing stuff earlier. Stage D is they look like this, they have findings of this, and then now they're on pressors and multiple pressors, or you've added a mechanical circulatory support. And then E is a tough one to pull out of. So stages of shock, trying to treat folks earlier along this progression, rate of progression. Briefly, RV infarction, we always sort of talk about this basically. So we know the clinical findings, either in shock clinically, but their lungs are clear and they have elevated JVP. If you have a PA catheter in, there's these in the setting of an inferior posterior MI, shows ST elevations. Obviously, by echo, you can see RV dysfunction. You might see RV dysfunction. The treatment is perfusion, free perfusion, and trying to maintain RV preload while the RV sort of wakes up, so to speak, from its shock state, from its stunned state, which usually happens quicker than the LV. And then trying to reduce the wedge pressure if possible. There are nowadays the right-sided impella we don't have here. We have a Bay State, and I know they have over at Hartford as well. Was also, I can tell you, we were all very hopeful that that was going to be a tool that was going to help these folks where we didn't have a lot of treatment for. It has helped in some cases. The incredibly high mortality we're seeing with use of that device has called it into question. Maybe we're just using it too late in folks and only in the sick of the sick, or maybe it's actually not very beneficial. Still very limited. We're limited in our ability to treat RV infarction. So trying to avoid it by getting them reperfused as quickly as possible is key. So ruptures, you can have either a VSD, so the rupture occurs within the septum and the flow goes from left ventricle to right ventricle. Free wall rupture, that's an obvious free wall rupture where it starts bleeding into the pericardial space. Well, here, all of which have incidence somewhere between 1% and 6%, even in the revascularization era. Their timing occurs somewhere between 3 and 5 days. It can be as early as 2.5 days. I can tell you that for sure. How they present, you should know, and how you diagnose them is sometimes difficult. I think we have seen here, and I think it's important to note that this isn't always just an obvious catastrophe. Anecdotes that they'll have a sentinel bleed to some degree, and then they'll seal it off. And I think trying to pick up on, and they'll just have some blood in there, but they haven't died just yet. and trying to pick up on that and being aware of it because of their late presentation, whether or not they're revascularized, you can actually save someone's life by being aware of this. So be aware of it. So what are the risk factors for having a mechanical complication? Well, late presenters, as we've talked about over and over again, elderly, female, low BMI, on anticoagulants. And guess what that looks like? Well, it's the same risk factors as intracranial hemorrhage. These are the folks to worry about. So pericarditis after STEMI. These are US guidelines. They push high-dose aspirin. The European guidelines are not consistent with this. Interestingly, US guidelines give it a 3B recommendation for, yes, steroids, but any NSAIDs outside of aspirin are potentially harmful. Interestingly, the European guidelines recommend NSAIDs for this. So I think the data aren't quite as strong for using any NSAIDs outside of aspirin, but you need to know the guidelines. Sudden cardiac death after STEMI. Again, this could be its own talk, broad brushstrokes, how to think about these folks. If they have VT or VF more than 48 hours after revascularization, they do have an indication for ICD. Okay. If they're not at high risk, for whatever reason, we can talk about that, you need to reassess them after 40 days. What if they're high risk, they don't meet indications for revascularization? Maybe a reduced EF now, maybe they presented with a cardiac arrest and have some non-sustained VT. Monitoring after, will a wearable device be helpful? It hasn't been as beneficial as we hoped it would be. But this 40 days is based on the one trial looking at this. We normally have to reassess them. How do you keep them safe during these 40 days is really what we're still trying to figure out. So ICD therapy, class 1A recommendation, ICD therapy indicated post-MI. Yes.
Sorry, quick question. On your last slide, what's the criteria that makes it high risk if they had a VT or VF event?
That's a good question. I think this is a clinical assessment of those who are high risk, mainly those with reduced LV function. But we also start worrying about folks who are having non-sustained VT after 48 hours after their event. Again, folks who, these are high risk, I'm sorry. Maybe folks who already had sudden cardiac death, maybe those who are not completely revascularized. I don't have any obvious high risk criteria that I'm aware of. It's been looked at, but it's more of a clinical gestalt that I'm aware of. Mensur going into EP, do you know the high risk features? I'm not aware of any of those beyond that which we've talked about. It's mainly a reduction in EF.
No, I don't know beside the EF and the non-sustained VT. And I know the data even behind non-sustained VT is like back and forth. You can do EP testing but now what I know talking to the EP attendings is they're just moving toward wearable defibrillators and then do reassessment in a few months.
Right. Good question.
Question on that also. That 40 days, does that include people that got revascularized and people that did not get revascularized?
I'm sorry, Justice, does the 40 days what?
That 40 days, does that include people that got revascularized and people that did not get revascularized? Or does it matter?
That's a great question. In the trial, they were revascularized patients. What do you do with a patient who wasn't revascularized? I don't know if that should change your thought process. That's a good question. I think those patients are clearly going to be at pretty high risk. I don't know of any data that says that, okay, if they're not revascularized because they presented so late, that now you're allowed to put it in an ICD. I think you probably still need to wait 40 days to see how our goal-directed medical therapy, possibly with getting them out of heart failure, improving their EF. I don't think it changes that, but that's a good question. Should we be thinking differently about those patients? Good question. So what guidelines state, it's a 1A after MI, if their EF is less than or equal to 35 due to a prior MI, or at least 40 days post-MI, and have some degree of heart failure, class 2 or 3. You're not putting ICDs in class 4 heart failure, folks. Also, class 1A, LV dysfunction due to a prior MI. They're at least 40 days post-MI, and their EF is less than 30, but they have no heart failure. So you sort of, I hear 30, I hear 35, I hear 40. Why all these different numbers? This is why. The number is 35 if they have evidence of class 2 or 3 heart failure. It's 30 if they don't have any heart failure. And then 40, less than equal to 40, if they have non-sustained VT or an EP study or inducible VF or sustained VT. So this can be confusing. And this is what our current guidelines state based on entry criteria into these trials. But those are why the numbers sort of show up differently. So my take-home points, at least, as we've talked about in STEMI, time is key. Time is muscle. But after 8 to 12 hours, we need to stop and think a little bit, okay? This timing or assessing timing when we think the event occurred is just as critical, if not more so in this day and age. We've got things that the system is greased down to take people as quickly as possible. We don't need to fix that anymore. In fact, I would argue, because it's so easily greased, the pathway, we need to stop and give a little more thought when it's not so obvious and the symptoms have been occurring more than a few hours, okay? When it's not quite clear, trying to help out with timing, knowing the troponin CPK curves is helpful. Opening anything but the culprit is only a 2B recommendation currently. We talked about the complete trial, but I think that was a handcuffed trial in my opinion. And you should have justification beyond the oculostenotic reflex, because every other piece of data shows that that's the right thing to do. Recognize there are stages, gradations of shock. Treat early. I think that's the key to that. Even though we don't have a trial to show that treating people early is beneficial, we think that trying to keep people out of that spiral should be helpful, because once they're down that rabbit hole, it's hard to pull them back up. 12 hours of constant symptoms, not intermittent. Worry about mechanical complications, even if they're revascularized. Okay. You need to know a little bit about lytic therapy. It is actually used out there, and if a COVID wave comes back in the winter, it's possible it could even show up here at this institution. Know the indications for medical treatment post-MI and for ICD placement post-MI, and why there's some variance in the actual exact number, which, as we all know, is hard to come up with exact number by echo. Yeah, it's just more stroke stuff. So I think I may have flown through that faster than I wanted to, because there's a lot to get through, and maybe I didn't leave enough time for you guys to jump in. But you have a chance now.
Hi, Dr. Robinson.
Hey, John.
Thank you for the great talk. I had a practical question. When do you say we would use Cangrelor, the IBP2Y12 inhibitor, in what clinical situations?
Yeah, that's a good question. I think I don't know the right answer. I can tell you at times that we consider it is especially in the shock patient or the patient who's intubated, who you're not sure if they're actually absorbing the agent that you're giving, whether it's through an OG tube or NG tube. That's a time when we consider it. I think that should be the time when I would most likely consider it. Whether or not you use that agent versus trying to give them through an OG tube or NG tube, their prasugrel, ticagrelor, or clopidogrel, but another P2Y12 inhibitor, and then treat them for a short period of time until you give that more time to absorb than you otherwise would. Use a 2B3 inhibitor, I think, is the question. I think those are the two options in that setting. I do think there is some data and clearly anecdotal evidence that in the shock patient, in the patients who's underperfused, especially that post-arrest patient, the intubated patient, the heart failure patient, simply relying on oral absorption of these medicines can have a higher incidence of acute stent thrombosis. So we need to think long and hard about either covering them with a 2B3 inhibitor, depending on their bleeding risk, or using Cangrelor. That's the time when I think it's most helpful.
Okay, thank you. And another question, Dr. Robinson, is I think we talked about this before. What are your thoughts on the theory of unloading the LV in STEMI?
So no pun intended, that's a bit of a loaded question. So John's referring to this concept, which is an intriguing one, of first unloading the ventricle before opening, unloading the LV before opening the vessel in an attempt to reduce or minimize reperfusion injury. Reperfusion injury has been the bane of STEMI treatment, revascularization treatment, since it began. It's this further extension of the infarct with opening of the vessel. And lots of different therapies, both medicine and not, cooling, what have you, have failed to show any benefit. So this is a concept in which you can significantly reduce or unload the left ventricle prior to opening the vessel in an attempt to reduce the reperfusion injury. Folks at Tufts are the ones who are big proponents of this, and there's some trial data to show that at least you're probably not hurting patients who you put the Impella device in and leave it in for half an hour before you open the vessel. And it's my understanding they're actually undergoing a efficacy trial currently. I don't know where that's being done, and I think we have to wait to see what happens with that. I think there's probably a role for it, especially in my opinion, in those folks with large MIs, especially that are heart failure. And I think the concept of putting an Impella in every single patient who comes in with a STEMI, and we know there's a huge spectrum of those patients, not just in the size of their infarct, but in the timing of their infarct, I think is with a device that clearly has significant downsides and risks, scares me and concerns me, but we'll see what the data shows.
Thank you, Dr. Robinson.
Sure.